Can see it.
Great, you have my poster. I'm trying a better poster. Hi, everyone. My name is Eungmi Lee. I am one of the fourth-year OBGYN residents. I wanted to present a project that I've been working on for the past year and a half called Fulfilling an Unmet Need, Integrating Family Planning Services into Office-Based Addiction Therapy. This is a qualitative implementation study. To give you a little bit of background on it, we decided to do this study because we have found that women with opioid use disorder have specific and unique needs when it comes to their reproductive health. When you look at the literature for the general population, about 40% of women report an unintended pregnancy. But then when you look specifically at women with opioid use disorder, they report about 86% of women with opioid use disorder have had an unintended pregnancy. So that's at about 2 to 3 times the rate of the general population. In addition, when you talk to them about the types of methods that they use, they often report the use of no methods or less effective methods. So we know that some of the most effective methods are long-acting reversible contraceptives. And so we were wondering what the cause of this disparity was and to see if there might be any way to bridge this gap. And one thing that we thought was very interesting is that the structure of office-based opioid addiction treatment programs, or what I will call OBOT programs from here forward, offers unique characteristics that we thought would be well suited to provide some of these services to women who might be seeking family planning services. Some of these things include frequent and regular visits with the same providers. Oftentimes, this is frequently nurse-driven, and so a lot of the nurses have really great relationships that they develop with their patients. And so especially when talking about something as complex as family planning, we thought that this might provide a unique and great opportunity as opposed to having patients come in for a one-time gynecologic visit where they don't really know the provider and they're trying to squeeze in a lot of information all at once. And so to try to see whether this might be something that would be feasible, we decided to do a qualitative study. And this is the first part of our study. We did interviews with providers in OBOT clinics. And then the next leg of our study would be to interview patients who attend OBOT clinics. And so in this part, I'm going to be presenting just the results from speaking with our clinicians. And so we performed semi-structured interviews with physicians, advanced practice providers, and nurses who all work at OBOT clinics. And we ended up interviewing about 19 people. In order to do this, we recorded the interviews, we transcribed them, and then we analyzed them using something called the PARIS framework, which stands for Promoting Action and Research and Implementation in the Health Sciences. And from there, we made a code book looking at very specific things like what is the evidence that supports this type of integration? What are the facilitators that could help us do this? What are some of the barriers? And then thinking also about the relevance of family planning in this. And so in doing this and in pouring through the different interviews, there were a couple of key themes that emerged that we thought were very interesting. So one was the high relevance of family planning services for patients who are attending OBOT clinics. And so we weren't sure, would this be something that's a little bit too different from what, patients are going to OBOT clinics for to be able to fold this in. And when we interviewed providers, one person said that spoke really to the disparity of gynecologic care for patients with opioid use disorder. So one person said, we know that our patients live in circumstances where they just don't always touch through in the way that we think of traditional outpatient care, and very few have a regular source of gynecologic care. So really, outlining that there is a need that's there. Another person really talked about the holistic nature of OBOT programs. And so really thinking about, not just treating opioid use disorder, but thinking about all of the different things that their patients might need. And so one person said, I'm pretty explicit about saying you are so much more than you are your substance use disorder and your disease, and you're a whole person. And so we're going to talk about those things too. So I don't think that they're surprised when they bring up things like family planning. Another thing was looking again at the structure of OBAT programs. And one thing that came up over and over again was thinking about the model and how this really lends itself to a conversation within family planning. And so someone said, I think the nurses have a huge role, especially in the OBAT clinic. I think that they have high touch points with patients. They see them more frequently. So I think there's definitely a role for them to engage individuals in the discussion. They become a good resource for patients and sort of a friend and ally. And so thinking about, what is really unique about these OBAT programs are the relationships that are really built over time and how that could really fit in nicely. Another big point that came up was really thinking about the impact of unintended pregnancy on recovery. And so this could go in a couple of different ways. A lot of the participants highlighted that if you're in the best place in your life, a kid is a hard thing to have. And so thinking about, patients who are in recovery, especially in early recovery, what that might mean, especially if this was something that they had not really intended, but are moving forward with. Another provider mentioned that, sometimes thinking really about being realistic with patients and sometimes how hard it can be to have an unintended pregnancy in the middle of recovery. And so one person said, I think as providers, we often worry that it's a false motivator because pregnancy does not cure addiction. And that's what a lot of women hope for. And so I think, again, this is just one view of one of the providers, but I think they wanted to sort of underscore that recovery is a long journey, and having something like an unintended pregnancy or something that wasn't planned for is something that can be really challenging in and of itself. And so trying to prepare our patients the best that we can. And then on the other hand, people did talk about, the impact of pregnancy on recovery in general and how it can be a huge motivator for some of their patients. And so one person said, I find children are an amazing motivator within this clinic. I think when patients are really struggling, if they are a parent, it definitely, like generally speaking, is my biggest motivator. And so really thinking about how there are lots of different ways that pregnancy can have an impact on recovery. And so really trying to think about this early and start having this conversation early with patients as opposed to later on when patients do have an unintended pregnancy. And so since we sort of established the relevance of family planning and the impact of pregnancy on recovery, one thing that we looked at was, whether this would even be feasible or possible. So thinking about the complexity of integration. And there were a couple of things that came up within this. One was thinking about how OBAC clinics really provide a really important service and are very mission driven. And so some of the things that you might see in regular clinics, such as, not seeing people who come in late, don't really apply in OBAC clinics that can add to some of the complexity. So one person said, our patients are never on time, so you might have nobody all morning, and then you have 7 coming at one time, and we never don't see a patient, so it can get hectic. So thinking about how to operationalize this, this can be something that's challenging that we need to work through in a way that both fits the mission, but then they're able to do on a day-to-day basis. The other thing that came up a lot, we're thinking about how we can not only start the discussion, but connect patients to the methods that they want, especially when it comes to long-acting reversible contraceptives. These are highly effective methods, but often ones that need to be placed by a provider. And so one person mentioned, when you book 3 weeks out, it might as well be 2030 sometimes if they're not doing well. And so finding a way that you could really operationalize providing those services when patients are there so that they can get, what they need on that day that they're there. Another thing comes with the complexity of providing LARC devices. So one person said, I actually did LARC training. It doesn't mean that I can actually put them in. Unfortunately, I haven't had the opportunity to actually do them. You have a certain number with supervision, so it hasn't happened. And so really thinking about whether there might be ways that GYN might be able to partner with OBAC clinics to help providers who are there get the training that they need so that they can do this on their own. And then the other thing as well is thinking about, seeing patients and all the things that you might need to cover within that short period of time. And so one person said, sometimes you can go through a whole visit, like getting through really basic substance counseling. And then at the end, you're like, wait, I didn't really leave enough time to have a more thoughtful conversation. And so if that is true, just in talking about substance use disorder, adding anything else in addition to that, especially something that can be as complex as, intentions for family planning, and also, methods that people want to use. It can add a whole other layer of complexity to the whole visit. And so in addition to some of the logistic things, one other thing that we thought was really interesting that came up were providers who brought up conflicting priorities. And I think namely, whenever you think about family planning services, I think the big thing is that, we want to meet patients where they're at, but especially for patients who might be vulnerable in specific ways, we want to make sure that we are not exposing them to coercion in any way. I think we talked about the impact of recovery on unintended pregnancy, but at the same time, we still should be sure that we're not coercing anyone into a method that they don't want, or into doing something that they don't want to do. And so, providers talked about the tension between, making sure that that patients' needs are met, but also making sure that they're not being coercive in the way that they are sort of counseling them about what they need, or about the methods that they're using. And then in addition to that as well, thinking about conflicting priorities. So we mentioned this in the complexity of integration, but what different things come first when you talk about the patient's needs? And so one thing that one person said is when they're immediately close to overdose or they're high risk of overdose, then that's what's going to kill them. That's sort of the provider's top priority or the patient's top priority. It's a test to tackle more than that, which is already a lot, as I said. And so thinking about those conflicting priorities, making sure that we are taking really good care of women in their substance use, and then things outside of that are sort of secondary. And then, as I mentioned before, the conflicting priority and making sure that, we're providing sound medical advice, but not being coercive. One person said, I have to check myself because it's easy to fall into a place where you're really counseling someone against pregnancy because they're sort of new in recovery. And so it can be really hard actually, because I very much want to respect what that person wants to do with her body and the choice of becoming pregnant. And then on the other hand, also feeling like it's my job to provide sound advice. And so, we found a lot of really interesting things by doing these interviews. And we think that we found a really unique opportunity to start thinking about family planning services and a better model, because as the model exists right now, it really is just trying to connect patients with gynecologists that they might not have ever seen, and seeing if there's another way that we can have this conversation and use a different framework to think about it, but at the same time, really understanding the complexity of what it means to provide patient services within OBOT programs. And so our big takeaway message, which we put at the top of our Better poster, is that despite logistical challenges, OBOT programs offer a unique opportunity to provide family planning services. And so our next leg in this journey is that we're really hoping to do some interviews with patients and really get their perspectives on what it might be like to offer or to receive family planning services when they go in for their OBOT visits. And then hopefully from there, we might be able to work with OBOT programs to see if we as gynecologists might be able to sort of integrate our services with them and provide some recommendations to implement some of these things.
Thank you so much for this presentation. We have only 15 minutes for everyone, so just as a friendly reminder to, and then if any questions, please raise your hand. Or do you prefer questions at the end of the all presentations?
I think we should ask them at the end of each individual presentation.
Okay.
Relevant.
Right.
I've been keeping an eye on the time too, and I think we have about only time for maybe 1 or 2 questions at most. So thank you very much, Dr. Lee. That was a great presentation. Are there any questions from the assembled group?
So I'll ask a quick question. You mentioned use the paresis model, but also you referenced using a auto decision support. So briefly, how did that fit into what your model intervention would look like?
Yeah, that's a great question. So the Paris decision framework is really thinking about how we can implement different things. And so there were different codes that we looked at. I think the big ones were looking at the evidence. And so we were trying to find themes around, patient experiences and clinical experiences that really support this. And then when we looked at different things within the Paris framework, they also include things like facilitators. So looking at the roles of different providers, the attributes that they have. And so I think all of those were very interesting, especially thinking about the model of OBAT programs. The Ottawa decision support was also interesting because oftentimes you just use one framework, but we ended up using the Ottawa decision support and really looking at how people make decisions around counseling patients, because I think that there's sort of a corollary between OBAT care and recovery as well as family planning services, because again, it's sort of this like long journey. They're both very nuanced. And so thinking about how you really provide counseling and have different discussions. And so for our Ottawa decision support, it was a lot about asking providers on, how they talk to patients about their recovery, and then how that some of those skills might translate into having conversations for their family planning needs and services.
Wonderful. Thank you very much. I think, Nasreen, we should probably move on to the next presentation.
Yeah, so Mara, were you able to share your screen?
It still says host disabled screen sharing, which I think is
Nasreen, you should
not a problem on your part. It's something to do with mine, but I did email it if anyone's able to open it up.
Okay.
I have the same restriction, so unfortunately, I can't.
Oh.
I also can't.
I'm not sure why. Okay, so this is the presentation that I just received.
No, that's not mine.
Okay. Yeah, I didn't get another one. I didn't get another one. That was the only one I got.
Oh, okay. Well, then it's not my turn.
I'm happy to go.
Okay, I was going to say, let's go ahead to the next one, and we have to be flexible.
Yeah, absolutely. Absolutely. All right. Well, hi, everyone. My name is Ragini Jala. Whoops. I think we lost the screen sharing. Ms.
Oh,
Reed.
sorry.
That's okay. I'm an infectious disease and addiction medicine fellow here at Boston Medical Center, and I'm currently doing my P32 training in research with trying to understand how we can prevent infectious complications of people who inject drugs. This particular study that I'm going to be presenting was funded by NIDA through a completed randomized control trial called the SKIN study. And I have some partial funding from my BU chart grant and through the RAMS Addiction Medicine Scholars Program. So our study is entitled Hospitalization: A Window of Opportunity to Reduce Racial Disparities in Treatment for Medications for Opiate Use Disorder. In the United States, the opiate epidemic is largely portrayed to affect predominantly white persons in suburban and rural communities, but recent data has suggested that opiate misuse and overdose deaths are really increased among all racial ethnic groups. We've seen steep increases in fatal overdoses among Black and Latinx persons, particularly as illicit manufactured synthetic opioids have entered into the market. And between 2009 and 2018, the rate of fatal opiate overdoses have increased from 116% among white adults to 289% among Black adults. And this has been further exacerbated during the COVID-19 pandemic. We know that medications for opiate use disorder save lives and they prevent overdose, but medications for opiate use disorders availability has been fairly slow to expand, and that's been most pronounced among Black and Latinx communities. And this has been exacerbated by years of systemic racism. Black and Latinx individuals face discrimination of access and provision of care, and studies have shown have been less likely to receive medications like Suboxone or Methadone, and have lower rates of long-term retention in OBAT. So it's unsurprising that Black and Latinx communities have higher mistrust in physicians than white individuals. Alongside of all of this, with the opiate epidemic and the fact that there's potentially systemic racism that's occurring among Black and Latinx individuals, hospitalizations have been on the rise, approximately 64% increase from 2005 to 2014. We have noticed that there's an increase in opiate-related hospitalizations. So a hospital stay could become a potential venue to treat not only opiate-related complications, but potentially link a person to outpatient medication for opioid use disorder. So what we aimed to do is we sought to understand, is there an association between race and ethnicity and lifetime access to medications for opioid use disorder among a cohort of non-treatment seeking hospitalized persons who inject drugs? In terms of our study design, this was a cross-sectional study using data from a completed randomized controlled skin trial that was done at Boston Medical Center. We included 252 hospitalized participants who injected drugs, and they were all hospitalized for a variety of reasons at Boston Medical Center between January 2014 to June 2018. In terms of the study measures we collected baseline survey data that included questions on demographics and specifically on self-identified race and ethnicity, as well as homelessness, employment status, history of incarceration, if a person had a primary care doctor. And then we also wanted to understand what the participants' trust in the medical profession was, and we used the standardized trust in medical profession scale, which is an 11-item scale that assesses satisfaction with medical care. In terms of our primary exposure and outcomes, our primary exposure, we broke down race and ethnicity into 3 categories. 1, non-Black, non-Latinx individuals, 2, Black, non-Latinx individuals, and 3, Latinx individuals. And then our primary outcome was, have the participants ever had lifetime treatment with medications for opioid use disorder, whether it's methadone or Suboxone. So if they've ever been offered this medication in their life. In terms of our statistical analysis, we present descriptive statistics to describe our summary characteristics using ANOVA and Pearson chi-squared tests. And then we developed a multivariable logistic regression model to understand and estimate the odds of lifetime receipt of MOUD, and we adjusted for our covariates. So our results are represented in this table, and among the 252 skin trial participants we included in our study, we had a mean age of 38 years. 58% of the participants were male, 62% had experienced homelessness in the past 90 days, 86% were unemployed, 85% had had a lifetime history of incarceration, and surprisingly, 66% had been linked to a primary care doctor at some point in their life. In terms of the racial ethnic breakdown of our cohort, we had 64% who identified as non-Black, non-Latinx, about 20% who identified as Black, non-Latinx, and 16% that identified as Latinx. In terms, and when we're looking at sort of our covariates, we found that overall mean scores in trust in medical profession were 3 out of 5. And this is a mean out of 11 sort of questions. And what we found in our results is that non-Black, non-Latinx, and Latinx individuals had a higher proportion of lifetime access to medications for opioid use disorders as compared to those who were Black, non-Latinx. And then when we adjusted for background characteristics and trust in medical profession, we found that race and ethnicity was associated with significant differences in receipt for medications for opioid use disorder. And our main finding is that compared to individuals who identify as Black, non-Latinx, the likelihood of prior MOUD treatment was significantly higher for non-Black, non-Latinx individuals with an adjusted odds ratio of approximately 9, and for Latinx individuals with an adjusted odds ratio of 4. And we did not see any observed statistical significant differences in prior MOUD treatment between the Latinx and non-Black group. So what does this mean? And in this study of hospitalized people who inject drugs, we found that non-Black, not Latinx, and Latinx individuals had significantly higher odds of lifetime treatment with medications for opioid use disorder than Black, non-Latinx individuals. And our study adds to this a growing body of literature around racial inequities that surround MOUD treatment access, and really highlights the urgency that we need to develop interventions to close this treatment gap so that we can provide more equitable addiction care. You know, we found that when you're looking at hospitalized non-Black, not Latinx individuals, most of those were white individuals with opiate use disorder, they were nearly 9 times more likely, and Latinx people were nearly 4 times more likely to receive medication for opiate use disorder in their lifetime. And it begs to ask the question, why is that happening? And this is not a novel finding. You know, we've had similar findings of racial disparities in MOED treatment. There was a study at the VA hospitals, and essentially they found that Black individuals or Black veterans were significantly less likely to get started on any medication for opiate use disorder as compared to getting started on nothing. And you know, what we need to understand is ideally, as addiction medicine providers, patients who have opiate use disorder would be offered a medication for their use disorder, and that would be determined by the severity of their disease. However, our findings are suggesting that perhaps some sort of systemic racism might be at play, and we need further studies to understand the extent to which this is contributing. Our findings also highlight the fact that there are opportunities to improve treatment access via a hospital stay, especially in states without Medicaid expansion. A hospital stay serves as a safety net for uninsured individuals, especially when people have limited access to primary and specialty care. And a hospital has the ability to offer various medications for opiate use disorder, whether it be Suboxone or Methadone, unlike other community partners. So really, there's an opportunity for us to use the hospital stay as a mechanism to close this treatment gap. And we know that when people are hospitalized for some acute illness, there's been literature that suggests that that's a great opportunity for change as a reachable moment. And perhaps we need to consider interventions on how we can leverage this reachable moment and try to engage this sort of racial disparity that we found. So overall, this was our study, and I'd be happy to take our questions from all of our audience.
Thank you so much.
Thank you, Dr. Jawa. It's a really interesting presentation. I think I wanted to see if anybody had any questions before I have a question. And we have, according to my clock, we still have a few minutes, right, Nisreen? I think we have.
Yes, yeah.
I guess 2 questions. One, I'm surprised at the prevalence of reported like engagement with primary care, and I was wondering if you could speak to that as like you know, in the context of this like incredibly low level of opioid use disorder treatment. And then secondly, I was wondering if you also asked them if they had ever been offered treatment.
Thank you for that question, Nora. So it's very fascinating. Our cohort is from a hospitalized group of individuals who sought care at Boston Medical Center. And so they're a slightly unique population as compared to sort of individuals who go to the community. Looking at other cohorts, our participants tended to have more engagement with, or at least saying that they had a primary care doctor. It's unclear as to how much they actually engage with their primary care doctor. We didn't really have any metrics to see that. So it's interesting that 72% of Black individuals had PCPs, but again, I think there's a lot of variability in primary care and addiction-friendly primary care, and even primary care doctors who ask patients if they have a use disorder. So I think it really begs the question that we probably need further research to try to understand why these individuals were not offered medications for their use disorder. Perhaps it was never identified. Perhaps they didn't feel comfortable enough. So, and then in terms of your second question, I apologize, I forgot. What was it again?
Were they offered treatment?
Oh, so I don't think that, so the question that we used for our measure was if they've ever been, if they have ever had experience in treatment, not if they've ever been offered treatment. I don't think that there's probably other literature out there asking if they've ever been offered and if they said no, but our study did not look at that. And perhaps if we were to do the study again, prospectively, this would be something to ask, that if we offer them, did they accept it? And then did that have an impact on why they were disparities?
Great, thank you very much.
Thank you so much for answering this question. Any more questions?
I think Dr. Horowitz actually kind of got at the question I was asking about the trust question, which I thought was an interesting way of looking at it. The differences are actually relatively small in the scale, though. And I just was curious, you mentioned different care settings and engagement, and I was wondering if, obviously your study is postulated on the idea that if you engage them in the inpatient setting when they're potentially more motivated, that would potentially lead to, either kind of a universal offering of treatment, and then you would hope universal kind of acceptance and engagement. But I was wondering these scores might change, for example, after a hospitalization, and how that might impact. In other words, how can we, what I'm trying to think of is, how can we, now that you've exposed these disparities in trust, how can we rebuild those and then potentially, engage and then get more people on treatment?
Thank you for that question, Dr. Ruberg. I think I'll tell you, when I hypothesized when we did this initial analysis that we would see that Black and Latinx individuals would have lower scores in their trust in medical profession, and that was not the case. I didn't really talk about that in the presentation, and that's quite surprising, and it makes me think perhaps the individuals who are Black, Latinx, who are seeking hospitalization are a unique cohort. They're perhaps different than people who are in the community, and maybe they are the ones that have primary care doctors. They probably feel more comfortable engaging with the medical profession, and so maybe that's why a hospitalization could be a place where we could leverage their trust in that setting and then engage them in MOUD. It would be very interesting to do future studies where we compare not only hospitalized individuals, but also those in the community, and then see sort of where their trust lies, because I think they might be different people. And so that's one of the biggest limitations in our study is we are very specific to an inpatient cohort. And so we can only really speak to the opportunities that an inpatient stay can offer. And you're absolutely right that the absolute value for the trust scores were really small, but it's a mean of 11 questions. So if the average value is 3, it would be 3 times 11. And so it sort of like increases with when you look at the actual final score. So thank you for that question.
Thank you so much. I got Mara's presentation. Do we still have more questions, or should we move on?
I think we have to move on because of time, right?
Okay. Okay, so our next presentation is about primary care for CVD risk revealed during pregnancy. Please introduce yourself and go ahead.
Thanks. And would you mind putting it on presenter or slideshow mode, just so that
yes,
nobody's
yep.
eyeballs break?
Mm-hmm.
Okay. And so I've also, I think, broken with the traditional form a little bit by creating separate slides for different sections of the poster so that we can zoom in on them when I'm talking about them. So I hope that helps, and I also apologize if it breaks rules. But I'm going to be talking about a review that I conducted with a fairly large group of collaborators across different departments. And this is a review of clinical practice guidelines and recommendations for the management of cardiovascular disease risk revealed during pregnancy. And this is specifically intended for primary care clinicians. So the motivation for this work, Nasreen, could you press once?
Yep.
Great. So I'm in the introduction section. So the motivation for this work is basically threefold. First, there's an increasing body of evidence to show that pregnancy is an early warning system for cardiovascular disease. It is believed that the physiologic stress of pregnancy can expose latent or subclinical chronic disease risk, specifically for cardiovascular disease. And that usually manifests through the development of hypertension or diabetes or other complications during pregnancy. The year after pregnancy is also a critical time to identify and intervene on cardiovascular disease risk. First, reproductive age individuals have generally very low levels of preventive healthcare use except during pregnancy. Pregnancy and the postpartum period are also a time when people often report being more motivated to undertake lifestyle changes than usual. And lastly, it's important to address pregnancy complications and any cardiovascular disease risk factors after a pregnancy in order to improve future pregnancy outcomes. And then the last sort of motivating factor was that most primary care clinicians are well positioned but ill-equipped to intervene on the pathway between pregnancy complications and future cardiovascular disease. So the traditional model of pregnancy-based care ends with a comprehensive postpartum visit with the obstetrician around 6 weeks postpartum. And at that point, anybody who requires further monitoring or follow-up for a pregnancy complication gets referred to primary care. So that makes primary care clinicians well-positioned, but I said they're ill-equipped, and that's because most primary care clinicians, specifically ones trained in internal medicine, report very little training in pregnancy-related health issues. And studies have found that they are very unlikely to incorporate pregnancy history into cardiovascular disease risk assessment or counseling. And so the goal of this study was to synthesize clinical practice recommendations for primary care clinicians who are caring for patients with a recent pregnancy-related CVD risk indicator. Now, I'll just talk about pregnancy-related CVD risk indicators in a little bit more detail. So these are pregnancy complications that reveal underlying or latent subclinical cardiovascular disease risk without necessarily directly affecting cardiovascular disease risk. There are a lot of them, but the three most common ones and the ones that will come up the most in this research project are listed in Table 1. Preterm delivery, hypertensive disorders of pregnancy, and gestational diabetes. Each of them affects up to 10% of pregnancies in the United States. And each of them is associated with approximately a twofold increased risk of cardiovascular disease over the approximately 10 years after the pregnancy. You can click again. So the methods here are that we undertook a systematic dual author review of clinical practice guidelines or recommendations or consensus statements that were relevant to postpartum primary care, which we defined as care between 6 weeks and 1 year after a pregnancy, and specific to patients who had a pregnancy-related cardiovascular disease risk indicator. And we limited our search to US publications between 2010 through 2020. And so you can see here that we identified just over 1,000 publications in our search through the dual author review process, looking at titles and abstracts. We identified 32 for full text review. And then after full text review, we had 12 studies that we ultimately included in our analysis. You can click again. So Table 2 here is an overview of the publications included. And if you click once more, we can zoom in on that. So the titles of the publications are listed at the top. And then I think the most interesting part is actually below the titles, where you can see the different sources, publication years, intended audiences, and postpartum focus of the various publications. I think the big takeaways here are that the majority of the publications are being published by the American College of Obstetricians and Gynecologists. And we also have some publications from the Endocrine Society, the American Heart and American Stroke Associations, the American Diabetes Association, and the American Academy of Family Physicians. But there was, and then the intended audiences include obstetric care clinicians, primary care clinicians, healthcare providers, and family practitioners. But none of them was specifically geared toward primary care clinicians and provided comprehensive guidance. They also occurred at an increasing rate over our study period. So just a few publications in the early 2010s, but then 2/3 of the publications have come out since 2018. And then still, most of them do not have a postpartum focus. So the majority focus on pregnancy health and pregnancy management, and then just a few talk about postpartum care. And of those, most of them are limited to the first 12 weeks after a pregnancy. Next slide. So going back to the large poster, after identifying these 12 sort of eligible publications, we reviewed them and extracted any guidelines that met our criteria of being relevant to primary care and specific to patients with pregnancy-related cardiovascular disease risk indicator. And then you can click again. So I'm going to zoom in on this, but it's not for you to focus on the content of the guidelines, but just to see how we organize them. So we organize them according to clinical population, as defined by having any or an unspecified pregnancy-related cardiovascular disease risk indicator. And then next slide. And then organized according to the presence of specific cardiovascular disease risk indicators. And the only ones that had specific recommendations associated with them were preterm delivery, hypertensive disorders of pregnancy, and gestational diabetes. Within each of those, then we organize the recommendations according to postpartum timeframe. And each recommendation also has an associated grade with it. So grade A recommendations are those that are strong based on clear and consistent evidence. Grade B recommendations are of moderate strength or quality. Grade C recommendations are based on very limited evidence, expert opinion, or best practices. And then actually the majority of recommendations were ungraded. So if you click again, I just want you to see here that grade A recommendations are shown with the dark filled in green bubbles are very few. And then grade B recommendations, where there's moderate quality of evidence, are also quite few. And then grade C recommendations and ungraded recommendations really occur throughout the recommendations. And the condition for which we found the highest quality evidence or the strongest recommendations was gestational diabetes. Okay, next slide. So we found all of this kind of difficult to digest, and we wanted to create something that could be of practical use. So we developed a practical guide for primary care clinicians, which summarized our findings. Based on all of the recommendations, this is what we hope primary care clinicians can print out and put on their walls. All postpartum patients within 1 year should be screened for pregnancy-related cardiovascular disease risk indicators. And it's really important that those be documented and communicated both throughout the care team and with the patient. 2, for patients with any pregnancy-related cardiovascular disease risk indicator, ideally within 3 months postpartum, they should undergo a comprehensive cardiovascular disease risk assessment. And we've detailed here what that assessment should consist of, and then based on their calculated cardiovascular disease risk over the following 10 years, what the treatment recommendations are. There's a big emphasis here on counseling and lifestyle modification, and that was pretty consistent across the recommendations. And then finally, box 3 is for patients with specific cardiovascular disease risk indicators, hypertensive disorders of pregnancy, or gestational diabetes, additional monitoring for hypertension or diabetes, respectively, and then again, more focused counseling on their individual risks for cardiovascular disease and CVD risk factors. Next slide.
It's not going. There you go.
So in conclusion, we found that clinical practice guidance for primary care clinicians to address cardiovascular disease risk revealed by pregnancy is limited by a lack of evidence. However, guidelines are pretty consistent in that any CVD risk indicator in pregnancy should prompt CVD risk assessment, counseling, and management, ideally within 3 months postpartum, and that management centers on patient education, empowerment, and lifestyle modification. We also identified some unique opportunities for the postpartum year, such as working on losing gestational weight gain and encouraging breastfeeding, which may improve cardiovascular health for the mother and are really specific to the postpartum population. And then lastly, continued research is needed to determine the optimal timing, content, and delivery of interventions to address CVD risk that is revealed by pregnancy. And that's it.
Thank you so much.
Thank you very much for driving.
No problem. Any questions?
That was a great presentation. I really appreciated it, obviously, and it speaks to something that I think about a lot. And I really like the concept of the study also, and that you're talking about bridging, from one new novel, essentially, risk factor, which should be, kind of recognized and translated. One of the things that I think is interesting is that when you think about this transition, and I wanted to ask you about it, is healthy people, who have children and then have a kind of, I guess, a risk identifying marker, then often return to apparent health, but then they often will also want to have children again. And so I think that the issue of managing some of these problems in the context of somebody who is a mother who has had a risk identifying hypertensive disorder or gestational diabetes, and then obviously is postpartum, it becomes, I think the challenge for the treating, and I see some of these patients in clinic, is how do you manage them in two different directions. One is whether they're going to have more children or not. And so I was wondering if some of the guidelines spoke to kind of like the selection of treatments and the engagement with future pregnancies.
Somewhat. If you go back to figure 2, which is the practical guidance for primary care clinicians, that's slide 7, just the second to last slide there. We did have a category for interpregnancy care, and there was actually some detailed guidance for that. Some of it is around birth spacing. So the ideal, birth spacing is, well, at a minimum 6 months between pregnancies, but ideally at least 18 months between pregnancies, in order to allow sort of the body time to recover from one pregnancy to be able to handle a second one better. And then obviously to, review medications and make sure that any potential teratogens are discontinued. Now, obviously that can really limit your options for treating cardiovascular disease risk factors. That said, at this young age, relatively, when we're talking about populations at risk for CVD, very few of them require pharmacologic therapy. And so I think then we can really lean on the fact that a lot of the advice is to emphasize lifestyle modification, and pharmacologic therapy is really reserved for people who are at high risk for CVD, which I think would be a pretty small population at this, in this age group.
Is this the slide that you were talking about?
It is, yeah. And so
Okay.
It's sort of buried at the bottom.
I see it now. Yeah, I didn't.
Yeah, maybe that's good feedback that it shouldn't be, but interpregnancy care sort of themes were around birth spacing, teratogen avoidance, and then obviously really early screening and early identification of any pregnancy complications in a subsequent pregnancy.
Thank you.
So also, I very much enjoyed your presentation. I just want to clear one question that the abstract that was written said something about primary care internists, but it was an inclusive criteria. It could be primary care internist, family practice, in terms of your screening criteria for whom the guidance applied to.
Yeah, our screening criteria were not specific to training background, but I come from an internal medicine background, and so I also know that the evidence that that primary care clinicians may not be adequately addressing pregnancy-related cardiovascular disease risk is mostly based on studies of internists. And I think there's good reason to think that family practitioners would be better at sort of retaining the pregnancy narrative through chronic disease care.
And just one other quick comment, I know we're running out of time, but because your poster really prompted me to look at, is a different question about whether these exist in the United States versus whether the guidance may exist in other places, and at least looking at some of the models in Canada that had really impressive translational handouts that covered all of these, including incorporation across, was interesting to me. You know, the United States, in deference to Rick, but they often have siloed organizations, and maybe that's an issue. So yeah, thank you.
Definitely wouldn't argue with that.
Thank you so much. So we still have one presentation left for e-cigarettes and their impact on periodontal health. Are you able to share your screen?
Let me just try. Yeah, I should be able to.
Okay.
Share.
You just may need to disengage your.
Yes, stop sharing. Yep.
Oh, I think I froze. Let me try that again. Okay.
How do you pronounce your name?
It's going to be Jyoti.
Jyoti. Okay.
Let me try that again. All right, can you guys see it?
Yes.
Okay, last but not the least, my name is Jyoti Sonkar, and I'm one of a kind, I guess, in this group of presentation because I'm not from BMC. I am from BU Dental. I am a periodontist and a clinical assistant professor. And for those who don't know what a periodontist is, I'm basically the dentist of the gums, bones, and dental implants. So in case you have some teeth mobility or you need an implant, you know where to go. So based on that, I'm going to be talking today about my study, which is more of a systematic review and throws light to one of our existing and least recognized epidemic, and that is e-cigarettes and how that impacts the periodontal health. Now, periodontal health would be more pertaining to tissues, hard and soft tissues around the teeth, and really play an important role in holding the teeth in the socket. If there's any issue with that, you're really looking at losing your teeth. And one of the things we decided to pursue this study was because everybody thought that e-cigarettes is a safe alternative because that's how they're marketed. And as of June 2020, United States passed a law in several of the states that supported unrestricted use of e-cigarettes, especially indoors, that really skyrocketed sales and consumptions of e-cigarettes amongst the youth and adult population. In the last decade, the sales and the consumption of e-cigarettes nearly doubled, and it's nearly tripled among the younger population. Now that's an epidemic because people don't know that it's really bad for your health. And the reason is they're marketed as a safe alternative. So the objective of my study was basically to review existing literature and see if there have been any studies that actually concludes whether e-cigarettes are safe or not. So a comprehensive search of most of the famous databases was conducted, and we included study from the beginning of time to the studies that were conducted up till May 2020. The inclusion criteria for these studies were any study that were more clinical and that specifically assessed the impact of e-cigarettes and not participants that were bouncing off between tobacco smoking, e-cigarettes, and recreational drug use. So we wanted studies that were clinical, in vitro, and any studies that aimed at intervention studies where people were trying to quit. Studies that were not included in this review were those that were not, that were reviews or meta-analysis, or studies that were not in English or didn't really, not some personal manuscripts not been published. So after reviewing the PubMed or these big databases, we shut down the studies from 5,000 to up to 12 studies that basically were more consistent in terms of study design, stratifications of the 3 categories that we were looking for, and had outcomes that really pertain to the impact. These studies were blinded. I was one of the few other investigators, so we did our own data extraction, and that really took us about a year worth of time to go through these full text and determine if these studies were eligible or not. So boiling down to 12 studies, we had about 6 studies that were clinical and 6 studies that were in vitro. Because of the shortage of the poster presentation, I didn't really include the charts that represented the studies, but instead I made more of a visualized, appealing representation that you can see in the results section. The clinical studies basically were divided between 3 categories, those that were specifically tobacco smokers, and those who were e-cigarette smokers. And then we had the non-smoking category that didn't really have any of these experiences. These people had different time lines in terms of the participants were either smoking e-cigarettes or tobacco cigarettes from anywhere between 5 years to 15 years. So we really got a lot of time variable, and that prevented us from doing a meta-analysis. And this was the best we could get out of this. What we found that, as we all know, that tobacco smoking is bad on health, and it not only impacts the general health, but also has an equally devastating impact on the oral health. But what was interesting was e-cigarettes that were marketed as a safe alternative did actually impact the oral epithelial cells. So as you can see, again, just to kind of give you a more brief explanation on what a plaque score means, it basically determines how well you've maintained your oral hygiene. So the plaque is basically a film of bacteria that we could find on your teeth and your buccal mucosa and basically your gums. So we did find that people who are exclusive e-cigarette smokers had significantly higher plaque scores compared to those that were not a smoker. These people bled more, although the tobacco smokers bled even higher compared to e-cigarettes, but e-cigarette smokers had significantly more bleeding compared to non-smokers. And what that tells you is that the tissues were more vulnerable, the tissues were more adept at getting damaged. Similarly, in terms of bone loss and having inflammatory mediators, the bone loss was more significant in e-smokers compared to non-smokers. And we didn't really find any differences in terms of inflammatory mediators in the blood cells between e-cigarettes and non-smokers. The in vitro studies where a lot of human gingival and periodontal ligament fibroblast cells were collected in a laboratory environment and exposed to different kinds of e-cigarettes with different flavoring agents, and they were treated from a minimum duration of about 2 days to about 4 days, where at a specific interval, these cells were treated with this e-cigarette concentrates. We had some really interesting findings. The concentrate did talk about how e-cigarette exposed and affected the cell viability. It affected the whole cell growth production and had a lot of altered effect on the reproduction, repopulation of the gingival fibroblast cells, the growth, and caused a lot of apoptosis, DNA damage, and caused reduced cause more of an impact in the viability of the cells. We also found a very interesting observation, which hasn't been noted to the best of our knowledge in any other studies, was that there was a dose and duration dependency seen. Now, there have been a lot of established literature that talks about dose and duration dependency on tobacco smoking, but e-cigarettes had a very limited knowledge on the same. So we found that the more often the e-cigarette concentrates were exposed to the cells, the higher the impact in terms of a negative impact was seen on the cell growth and the DNA damage. Another key finding that we saw was the flavoring agents of the e-cigarettes. E-cigarettes come in a variety of flavoring agents, candies, eucalyptus, and any of those popular flavors that's really common among the teens. We found that menthol had a very strong negative devastating impact on the periodontal cells replications and growth. And one of the possible explanation for this finding could be that menthol actually stimulated one of these transient receptor potential NCARIN1. These are some of the receptors that plays an important role in stimulating inflammatory responses, and they stimulate cyclooxygenase and prostaglandin pathways that really causes your cells to stimulate any cytotoxic cellular and pro-carcinogenic activities. And as you all know, this whole stimulation of these pathways will lead to a negative impact on the cells. So this was something that we hadn't been able to find in any of the existing literature. And the review is just a stepping stone. I mean, it's this review basically leads a pathway for us to do some clinical control trials, which have been really difficult because of the fact that we really do not find a really case control population that only smokes e-cigarettes. Most of these populations are either have had tobacco smoking experience or any other recreational drugs. So by this systematic review, we really hope to move on to the next step, is to find some funds to conduct some clinical control trials. So in conclusion, we would like to say that there is a limited evidence of the impact of e-cigarettes on the periodontal health, and they're not really safe as they are marketed. And there is a dose dependency, dose and duration dependency that's been seen, and flavoring agents do play a very important role. And of course, we do need some more well-designed, larger scale clinical control trials, but this is just the beginning. Thank you, and I'll just be open for any questions.
Thank you so much.
I think our time is short. Thank you very much for that presentation. It was really interesting. I'm interested in that because there's a lot of interest in cardiovascular effects of e-cigarettes. And in fact, Boston University is funded to do a large e-cigarette research project with one of my colleagues here in cardiovascular medicine, two of my colleagues, Naomi Homburg and Amelia Benjamin by the American Heart Association. One of the questions you already kind of anticipated, and that was, I was going to ask you, many people who use e-cigarettes also smoke tobacco as well. So it's difficult to kind of reconcile the findings that you find because they often co-use. And the other question was, which I think some of your in vitro work, which is impressive to combine them in one project, is to explore different flavorings to see how they impact. But you might, just as a note, you might consider connecting with the cardiovascular investigators. There is definitely a connection between periodontal health and cardiovascular health. A lot of it's confounded by things like smoking and other and risk factors that affect both, but it would be an interesting potential collaboration for you.
Yeah, looking forward to that. So,
any more questions?
What's one question? It's a little bit unusual to combine a clinical and a basic science systematic review. As you said, there's a lot of heterogeneity in even the clinical work. So how to synthesize that in a narrative review? And I guess my question is, how do the in vitro models actually compare to answer the question, which is it safer than smoking tobacco, or how dangerous it is versus not smoking at all? Because those seem to be the questions. And does it really do those models where you're looking at fibroblasts with an exposure help? I guess that was my question. Why it was interesting you combined both of them, because that's unusual in my experience.
Right. I mean, one of the reasons to combine was that because of the lack of case control studies that specifically did look at e-cigarettes. It was really vague. We didn't really find a lot of data on that. And in vitro studies were one of the ways for us to find evidence in a controlled laboratory environment to exactly just study how e-cigarettes impact these cells. And we were able to find data that looked at the possible dose duration and as I just mentioned, the flavoring agents, which was really hard to find in clinical trials, or something that we look forward to conducting in the future. To answer your questions, are they safe? I mean, it's a limited results, but it's out there for you. I mean, it's definitely not safe, and that's the problem that as a down community I have to these e-cigarettes marketing companies, that if you want to market them, at least have some sort of a warning on the pack, the way how you have it on tobacco smoking. People consume e-cigarettes knowing that nothing's going to happen to them, and that's one of the worst things that you can actually lead the young adults onto is false information, misinformation. So of course it's not as negatively impacting the way how a tobacco cigarette smoker would be experiencing, but it's definitely not safe compared to someone who doesn't smoke at all. And again, this is just a tip of the iceberg. We don't know what we're getting ourselves into. I mean, we don't really have any data, like 30, 40 years of data to know that apart from just impacting the cells, is it causing any permanent alterations? I mean, we don't know anything about these agents, these flavoring agents that I just talked about. So it's just interesting to see what we can find, and I do hope to use this study as a stepping stone to get some sort of a K2 or R01 grant to actually do some clinical trials. I mean, I'm in touch with Juul. I don't know if you know, Juul is one of those brand e-cigarettes that really market that they're really safe, and you know, they really market it as something that if you want to try to quit tobacco smoking, just get on Juul. And I'm like, no, that's not how it is. So we're in talks to get some of the controlled trials that we're looking for, population that's specifically smoking e-cigarettes, and hope to get some sort of the study going on.
Thank you.
Well, thank you again for answering the questions. Any more, or was this the last one?
I guess I'm the last one.
And thank you so much for all of you for all the great presentations. It was a pleasure to have you all with us. And then please rejoin again the main room.
Thank you.
Thank
Nice
you.
to see you all.